Good evening, everyone. I'm Dr. Amit Thavkar from Sun Pharma. Welcome you all to the first edition of Glaucoma Grand Rounds. At Sun Pharma, it is our constant endeavor to be at the forefront to drive and facilitate scientific meetings. In the corona pandemic, we are slowly getting used to the so-called new normal, and virtual meetings have become part of our lives. Let me ensure right at the beginning that the Glaucoma Grand Rounds is not just another virtual platform, but in fact, its unique approach offers a great learning experience for each one of us. It is said that real learning comes from real-world experiences. The Glaucoma Grand Rounds is designed keeping the same ideology in mind. This innovative initiative is the brainchild of Dr. Ronnie George and Dr. Manish Singh. Through their efforts, they have conceptualized an exciting program for all of us. We are also so fortunate to have Dr. G. Chandrasekhar as the chairperson to guide us in this journey. We thank and welcome Dr. G. Chandrasekhar, Dr. Ronnie George, and Dr. Manish Singh. I also take this opportunity to welcome and thank the entire esteemed faculty of Glaucoma Grand Rounds. It is always a pleasure to engage with glaucoma experts like you through such innovative forums. With pleasure, now I would like to introduce Dr. Manish Singh. He is the director of SLR Eye and Retina Surgeons Private Limited. He is senior consultant at BBI Foundation VIP and joint treasurer of the GSI. With this, I hand over the forum to Dr. Manish Singh for further discussions. Thank you.
Thank you, Dr. Amit. Before we go to the presentations, I'll quickly introduce our chairperson. So it's really an honor for me to introduce Dr. G. Chandrasekhar sir. Sir needs no introduction. He's an astute clinician, a passionate teacher, and because of his contributions, the Director of Education at LVPI, there is a G. Chandrasekhar Chair of Director of Education was created in 2003. Sir has trained more than 50 fellows, more than 100 publications, and also has been the President of Glaucoma Society of India from 2005 to 2006. We are really fortunate to have Sir in our program. I'll quickly introduce the panelists for today's program. We're also very fortunate to have Dr. B. Shanta ma'am. Personally, I've been honored to have done my fellowship under Madam. She is currently the Director of Department of Glaucoma, Shankar Netralaya. Madam has done her diploma in ophthalmology from Joseph Eye Hospital, Tiruchirappalli, and also training from CMC Vellore with Professor Ravi Thomas. Multiple publications. Madam has also been the past secretary of Glaucoma Society of India. We're also fortunate to have Dr. Andrew Braganza. Sir has done a post-graduation from PGI Chandigarh and currently the professor and for a department of CMC Vellore, and also is in charge of the glaucoma services. We have Dr. Gauri Murthy. Madam is the Chief Glaucoma Services at the Prabha Eye Clinic and Research Center. She has got extensive experience in managing difficult glaucomas and specifically endoscopic surgeries. She has also received the Platinum Award for Best Publication in IGO for 2019. We have Dr. M. Bhaskaran sir, who is a senior consultant in glaucoma services at Shankar Netralaya, formerly a clinical scientist at Singapore Eye Research Institute and Singapore National Eye Center, and has got more than 200 publications and vast experience, book chapters, and has also had 8 co-patents in the field of glaucoma. We also were supposed to have Dr. Aditya Nyog, who is the consultant ophthalmologist at Foresight Worldwide. Because of certain personal emergencies, sir is not able to join us. We'll be definitely missing Dr. Aditya Nyog sir for this presentation. I'll quickly introduce moderators, and then I'll hand over the session to Dr. Ronnie George. Dr. Ronnie George sir is currently the Deputy Director and Senior Consultant Glaucoma Services at Shankar Netralaya, has got more than 140 publications, more than 250 lectures, and also being the section editor for Indian Journal of Ophthalmology and the editorial board of Journal of Glaucoma. We are also fortunate to have Dr. Ganesh Raman. He is the head of department, Arvind Eye Hospital, Coimbatore. He has done his post-graduation from Indore and a glaucoma fellowship from Arvind Eye Hospital, Coimbatore. And the third moderator, we have Dr. Nikhil Chaudhary. Sir has been the consultant glaucoma and neuro-ophthalmology in Shankar Netralaya for 2006 to 2010. He has done his fellowship from LVPI and post-graduation from Shankar Netralaya, and also has received the GSI Pfizer Best Paper Award at the 4th SIGIC Chennai conference. So I'll now hand over the session to Ronnie George sir. And yes, sir.
Thank you, Manish. And I must confess that I should give credit when it's due. It was entirely Manish's brainchild. He roped me in just to, uh, you know, do nothing much. So thanks, Manish. It's entirely his brainchild, and credit should go to him. So without any further ado, I think we will maybe I'll introduce Dr. Manju, and then Dr. Manju can start her case. So LLP and her DMB from Narayan Netralaya. She did her fellowship in glaucoma from RIO Bangalore, and she's working as a consultant at Giridhar Eye Institute, Cochin. I know that she's very passionate about glaucoma, and she's very active and one of the upcoming young glaucoma specialists in Kerala. So Manju, why don't you go ahead and present your case? So Manju is going to present the case, and then we will have 7 minutes for discussion, and then she'll have a little wrap up after that. Can you unmute yourself, Manju?
Yeah. Good evening, all. I'll be presenting two cases. The first one was a 38-year-old male. He was complaining of diminution of vision and pain in both eyes since 2 days. And he was seen by a general ophthalmologist in town, and he was diagnosed as having primary angle closure disease in both eyes. He was started on timolol eye drops and tab Diamox and referred to us for bilateral YAG-PI. On examination, his uncorrected visual acuity was counting fingers 3 meters in both eyes, which was improving to 6/9 with correction. Cornea was clear, AC was shallow, both central and peripheral. Pupils were sluggishly reacting. Disc examination showed healthy with CD ratio of 0.4. His intraocular pressure was 26 millimeters of mercury in both eyes, and gonioscopy revealed appositional angle closure in both eyes. So with this, our diagnosis was primary angle closure in both eyes. However, the patient was an auto driver by profession, and he told that he never had any problem with his vision prior to this episode. As his uncorrected visual acuity was counting fingers 3 meters in both eyes, we went back and checked his refraction again. So his best corrected visual acuity was 6/9 with -4 diopter sphere. So with acute onset of myopia with an angle closure, we suspected a drug-induced secondary angle closure. So on asking further, he told that he was having headache and was taking topiramate 25 milligram per day since 2 weeks. And we did a UBM which showed ciliocoroidal effusion and anterior rotation of the ciliary body, which confirmed our diagnosis. So we asked the patient to stop topiramate, started him on topical steroids, cyclopletics and anti-glaucoma medications, and on follow-up on 5th day, the vision improved and angles were opened up. So another case was a 58-year-old female. She presented to us with redness in the left eye since 2 days. On examination, his vision in the right eye was 6/12, not improving with any correction. And in the left eye, the best corrected visual acuity was 6/9. The conjunctiva was showing mild congestion in both eyes. Corneas were clear. AC shallow in both central and peripheral. Pupils were sluggishly reacting. Discs were healthy with a CD ratio of 0.3. His intraocular pressure was 16 millimeters in the right eye and 15 millimeters in the left eye, and gonioscopy revealed appositional closure. So we thought the diagnosis as primary angle closure suspect, but she was seen by us 2 months back. At that time, her best corrected visual acuity was 6/6 in both eyes. Anterior chamber was documented as deep. However, gonioscopy was not done at that time. Her intraocular pressure was 15 millimeters of mercury in both eyes, and the discs were healthy with a CD ratio of 0.3. So this was the refractions in 2 visits. 2 months back, she was 6/6 with plus 1.25 diopter sphere with plus 1 cylinder at 80 in the right eye, and plus 2.25 diopter sphere with 0.5 diopter cylinder at 180 degrees. She was 6/6. In the present visit, her vision was 612 without any correction in the right eye, and in the left eye 6/9 with +1 diopter sphere with +0.5 diopter sphere at 180. So we noticed a myopic shift in refraction in both eyes. So again, with this myopic shift with an angle closure, we suspected drug-induced secondary angle closure. And on further questioning, she told she is taking TAP Diamox once daily since 1 week, which was prescribed by her ENT surgeon. So again, we did the UBM, which confirmed our diagnosis, and we advised her to stop Diamox, started again on topical steroids, cycloplegics, and anti-glaucoma medications, and vision improved and angles opened up in 5 days' time. So I'll stop here for discussion.
Thank you, Manju. Can you just stop sharing your slides
Yes,
for a
sir.
minute to see the panel? Could I request the panelists to unmute themselves? Yeah. So there are two cases here which I think illustrate a fairly common presentation of bilateral simultaneous drug-induced angle closure glaucoma. Dr. Shanta, could you think about some other possible etiologies for bilateral simultaneous angle closure? The first lady was, the first man was 38 years old and the second lady was similar age. Anything else which you would like to rule out in these people?
I mean, if they did not have a history of
Yes.
these drugs having been started. I think we've had almost 14 to 15 cases of BKH which presented as acute bilateral angle closure. And again, when we performed a UBM, we found choroidal effusion in these patients. So that necessitated a completely different line of management. We've also seen multiple cases of idiopathic uveal effusion in the young, which presented in a similar manner with bilateral acute angle closure with the presence of ciliary body effusion. We even had unilateral cases of uveal effusion presenting, and a little difficult to identify what the case, the etiology could be. There are various scenarios which have been described, but the most common causes have been BKH and idiopathic uveal effusion as far as I can remember.
So the importance of a good history is probably critical here, and also maybe the fact that you need to do a refraction in these cases. The next question I have is, with Diamox, you get a peculiar problem, because I'm just asking you whether you have seen this happen post-cataract surgery, especially in the days when we used to give Diamox post-cataract surgery. Whether anybody has come across it that way. Gauri, you want to say something?
Yeah, we used to post-operatively almost 10 years back. We no longer do so, but I don't remember any patient presenting with a this kind of an idiosyncratic, drug-induced angle closure with Diamox. There have been systemic side effects, but not this. I must admit that I have not seen this.
There have been from Arun, I think it was typically in the times when ECCIOL was done and post cataract surgery, Diamox was given. There was an idiosyncratic reaction and the patient developed actually bilateral subsequently choroidal effusion, and when they stopped the Diamox, it subsided. So it was published actually. Arun has published it actually.
So typically what happens is you see it after the second eye.
Second eye.
Because for all these things, it's important to remember you have to have a sensitizing dose and then an inciting dose. And I think Manju talks about it a little bit later in her presentation too. But I think it's an important message that we need to get across. Dr. Andrew.
One patient, Ronnie.
Yeah.
Yes.
I've seen one patient when I was visiting somebody, cataract surgeon predominantly, cataract surgery being planned in 3 days' time between the two eyes. But before they could start the second eye cataract surgery, the patient developed glaucoma in that eye, and the operated eye also was shallow. And the practice pattern apparently was to give Diamox preoperatively before cataract surgery.
Okay.
Well, I think that Diamox is I mean, this kind of reaction, Diamox, is actually extremely rare. I've been dying to see it and I haven't seen it yet. But, you know, I mean, I maintain a high index of suspicion and whatever it is, but I still haven't come across the patient. And I think it is fairly rare. It definitely does exist, but it's quite rare. So,
could I just ask everybody?
There are patients who do present, primary angle closure patients who present with primary angle closure in both eyes, and that's extremely rare. Yes, you should not think of it as the first diagnosis. But when you've ruled out everything else, that's also something that you have to consider. And I've just kind of finished having to do a lens extraction plus trabeculectomy in both eyes within 1 week for a lady who came to us like this. And, you know, we tried to rule out everything else, but finally down to the thing that it's a primary angle closure that's presenting like this. So, yeah, those are the possibilities, I think.
So, and just a quick, I mean, if anybody disagrees with me on this statement, the commonest drug that causes this is topiramate. Has that been everybody's experience, or has anybody has any other experience?
Yeah.
I think while there's a long list of drugs which can cause it, the commonest is topiramate, and with Diamox you may never get a history of a sensitizing dose because there is a cross reaction with certain other groups which can be the sensitizing dose. In terms of these patients undergoing surgery, cataract surgery, anything different about the way those eyes behave?
The eyes with drug-induced angle closure like topiramate later when they undergo cataract surgery. I must admit that I have not operated on a cataract on any of these patients because they're relatively younger patients who present to us in their 30s or in their 40s. So, and one person has been as young as 18, this drug-induced angle closure. So I must admit I have not done cataracts for them. But what Madam said, Dr. Shanta said about VKH presenting like this, I think that is very, very important because in the middle-aged or later women, their VKH and the full-blown thing develops a little later on, that full syndrome. So there, of course, there are issues with cataract surgery, but I must admit I have not operated on any of these patients till now, those who have had drug-induced angle closure.
So I've had to do a few, and they have been, and the ones which are the worst are the ones who have been started on pilocarpine outside.
Oh, okay.
And that really sets up such a bad inflammatory reaction post-operatively that it's very, very difficult to handle. It's a nightmare because it's a dense inflammatory membrane post-operatively. Intra-op, there's not much of an issue.
Okay.
I think one message if you can get through is that you try and avoid using pilocarpine if you suspect.
That is true.
So I think I have another minute, and before I go, I'd just like to ask Dr. GC one question. There was a report out of LVP some years back, maybe 10, 12 years back, about a bilateral topiramate-induced angle closure, which required a YAG peripheral iridotomy. I don't know whether you remember the case. So you're muted.
If it was done, it was not right because the diagnosis may not have been suspected at that time. So the pilocarpine and iridotomy are not required, should not be used in this case if you can make the diagnosis. Having said that, I will reiterate the point that Andrew was making. When you get these cases in a row, sometimes it happens. Everybody in the service is geared towards diagnosing drug-induced bilateral closure. So there is one patient whom I was asked to see. There was something unusual, and because of the asymmetry of the disease between the eyes and some kind of cupping and iris changes in one eye, I took the decision that it is not drug-induced, it's a bilateral angle closure. We went ahead and gave pilocarpine and did a PI for that patient, and she did well. So bilateral angle closure is not that rare in our context. We need to remember that as a possibility and look for certain signs of the bilateral angle closure. The question that I would have for the experience for the other group, if I am allowed to take the discussion further, is some of these cases I have not seen one myself, but colleagues discussed. Some of these cases develop such a severe acute attack that there is an ischemic element of the iris and there is a superadded inflammation that happens.
Inflammation, definitely.
As what we are talking about. In those situations, what's the line of treatment? What experience people have? I would like to learn.
Sir,
Sir, if I may add, Ganesh here, I think it depends on the age of the patient. The younger the patient, less you have nuclear sclerosis, they sort of reverse back very quickly. The patient, you'll have more nuclear sclerosis and they incite more inflammation, especially if you're planning cataract surgery. I find that there's a iris plaster to the lens and there is little bit of asymmetry between the eyes.
I think the important, Gauri, you wanted to say something?
Yeah, I said that inflammation is a definite feature in most of these drug-induced angle closures. If we look carefully, there is subtle inflammation even in those mild cases. And one or two we have seen with frank inflammation, like GC sir said. And the people who had frank inflammation, we have started them on hourly steroids and even systemic steroids to reduce the inflammation. The iris is boggy and the ciliary body is almost, swollen and edematous. So we can see the thickened iris even on the UBM. So
yeah, I agree. We have had a similar experience, had to give systemic steroids on occasion, and this is worst when the patient has been on pilocarpine. The rest of the time, it's relatively easy to reverse, provided you pick them up early. Sometimes they come to you after 3 weeks on the drug, and by that time it can be a bit of a mess. So I think we're more or less out of time. Just one quick point, and that is that history is really important, and Manju illustrated that in both the cases, that you looked at the refraction before and now, and that is why your answer is the simultaneous cases. Primary angle closure does not present with a change in refraction, an acute change in refraction like this. I think we're more or less out of time for the discussion. Manju, you want to finish your presentation?
So the mechanisms of angle closure include relative pupillary block is most common, wherein you need peripheral iridotomy as the first line. Other mechanisms include anterior pulling mechanisms, which you get in neovascular glaucoma, uveitic glaucoma and eye syndrome, and posterior pushing mechanism in malignant glaucoma and drug-induced angle closure. So for the drug-induced bilateral secondary angle closure, there are many drugs which are listed. Most commonly sulfa-containing drugs, then antipsychotics and antidepressants, many are there. And it is supposed to be an idiosyncratic reaction, and 3 supportive reasons which are proposed are: one is a very small proportion of the patients who take these drugs will develop the drug-induced bilateral angle closure, and the next is low or even subtherapeutic levels of the drug can cause the condition. And the third is there are instances where the drug overdosage occurs and that will not result in the bilateral angle closure development. So coming to the pathophysiological mechanism, it is not clearly understood, but widely proposed mechanism is exposure to the drug causes an altered serotonin metabolism in the aqueous humor, which causes ciliocoroidal effusion and ciliary body swelling, which in turn lead to anterior rotation of the ciliary processes and forward displacement of the lens iris diaphragm. So coming to the demography, age is not a discriminatory factor. The lowest age reported is 5 years. It's more commonly seen in females, and the onset of symptom can be as early as 3 hours, which was reported with acetazolamide, to 262 days is the longest one, which was reported with topiramate, and the dose also can vary. It can be 250 to 750 milligram with acetazolamide and 25 to 100 milligram with topiramate. Coming to the clinical features, the most important feature is myopic shift, which can go up to 10 diopters due to forward movement of the lens iris diaphragm and lens thickening due to reduced zonular tension. There can be conjunctival congestion, corneal edema due to raised IOP, which can go up to 80 millimeters of mercury, shallowing of central and peripheral AC with closed angles. Usually there will not be any pupillary abnormality. Optic nerves may be normal and macular folds are also reported. B-scan shows peripheral choroidal effusion, and ultrasound biomicroscopy shows the ciliocoroidal effusion with anterior rotation of the ciliary body with closed angles. So coming to the management, we have already discussed discontinuation of the offending drug. Pilocarpine exacerbate the clinical symptoms and sign, and YAG peripheral iridotomy is ineffective. We can treat with topical steroids and in some cases need systemic steroids, topical anti-glaucoma medication, cycloplegics, and usually complete recovery in 1 to 2 weeks. So although drug-induced bilateral secondary angle closure is rare, the implicated drugs are commonly prescribed, so collectively the entity may be more common than might be expected. Drug-induced secondary angle closure is an ophthalmic emergency, and it is critical for the clinician to distinguish this from the primary angle closure, as the treatment protocols are markedly different. Careful history and examination are essential in differentiating the two conditions, and the most reliable sign to differentiate primary angle closure from drug-induced secondary angle closure remains the demonstration of a myopic shift in the latter condition. Thank you.
Thank you, Manju. That was a very interesting case. One last question to you. Why did the ENT surgeon give Dimox?
That I don't remember, sir. She just told it was prescribed by ENT physician.
Okay, fine. I thought they had. I didn't know what the indication was. Anyway, thanks. Over to you. Over to you, Manish.
I think we'll move to the next case. Thank you, Dr. Manju. So Dr. Ganesh, will you?
Thank you. Thank you, Dr. Manish. I'm very happy to introduce Dr. Smita Panda. She is the Associate Consultant of Glaucoma Services in Shankar Nethralaya. She has passed her MBBS from Jawaharlal Nehru Medical College in Belgavi and her MS in Ophthalmology from Subhash Chandra Bose Medical College and Regional Institute of Ophthalmology in Cuttack. She has numerous presentations and she is a very important contributor for many of these scientific forums which we have in our state, in our country, and she is in 2017, she was the best outgoing fellow of the Glaucoma Society of India, the All India Smita Panda.
Thank you, sir. Is the presentation visible, sir?
Yeah, now
yes, please.
Okay.
Now it's visible.
I thank the organizing committee for this wonderful opportunity. So today I'll be discussing about a very rare case of secondary glaucoma. So we had a 39-year-old male working in entertainment industry who came to us with complaints of loss of vision in right eye for past 1 year. Both eyes had intermittent pain and redness for past 1 month. He had past history of photophobia and he was using colored contact lenses for that, and he was wanting a permanent solution for that. So there was a history of cosmetic intraocular surgery done in 2014 in India. After that, in 2018, he was diagnosed with secondary glaucoma and started on medication for the same. He gave a vague history of some kind of surgical intervention also done for that. The patient was using timolol, brimonidine combination, tafluprost, and acetazolamide 4 times per day when he presented. His anterior segment was so. Right eye had lost vision. There was an iris prosthetic implant with corneal edema and IOP of 32 millimeters of mercury. Left eye vision was 6 by 7.5 with correction, with again that same implant and IOP of 40 millimeters of mercury. Gonioscopy showed open angles. The left eye fundus, whatever that could be seen through that small pupillary aperture, showed advanced cupping. The macula was normal, and this is the 10-2 of the patient showing advanced damage. We did UBM to find out the condition of the structures behind that implant, and we saw that the iris was missing from 4 to 8 o'clock position. Here you can see the iris stump behind the implant and missing at 6 o'clock position. Iris present at 1 and 2. This was left eye UBM. Again the iris was absent in few clock hours, and small stump of iris at 7 o'clock, 8 o'clock and other areas. The specular count of left eye was very low. So what exactly was this device? It is bright ocular prosthetic iris device manufactured by Stellar Devices, which is a US based company. The diameter of the device varies from 11.5 to 13.5 mm. They customize it according to the wide to wide diameter of the patient's eye. The thickness varies from 0.3 to 0.5. Along the posterior sectoral grooves are there, which allow for aqueous flow, it seems. And it has got 5 rounded triangular edges, as you can see in the picture below. With the help of these edges, it helps it to tuck to the iris. This device had a predecessor known as nuclear iris, which was banned because of several adverse effects it was causing. Neither of these devices are approved in United States or European Union. What exactly can this device cause? The implant corneal touch at periphery damages the corneal endothelium. The surface irregularity and the hinges rub against the iris and cause recurrent inflammation. This kind of chronic anterior segment inflammation and pigment dispersion and peripheral anterior synechia can lead to glaucoma. So now our case is a one-eyed young patient with advanced uncontrolled glaucoma and decompensating cornea. He needs surgical intervention for intraocular pressure control. The patient was very reluctant for implant removal because of his profession. So what should be the management like, and do you feel that implant removal is necessary? I would like to open the question to the panelists.
Dr. Smita, I would think that definitely implant removal is necessary because that is the root cause of all the problems. So even though the patient may be a little reluctant, I think we need to counsel him, and the importance of preserving whatever vision is there in his left eye, I think takes precedence over any cosmetic benefit that he has had from this. Unless you remove the inciting agent, treating the secondary effects is not going to help us. Of course, along with the implant removal, we will also have to address the angle damage and also the long-term corneal problems we have to anticipate.
Yes, sir.
Dr. Andrew, your take on this?
I would say that this patient has been so motivated to put in that implant that it's going to be very difficult for him to agree to its removal. Also, that implant has now caused enough damage, and removing the implant is not going to solve his problems. I would say that we have to control his pressure, and the best thing to do is leave the implant there and put in a tube. So, that's Gauri shaking head.
No, sir, no.
Dr. Shanta? Dr. Shanta?
I agree with Gauri that this person has, within 6 years, lost perception of light in the right eye and potential path towards blindness in the left eye. And it's clear that the implant is causing the problem. So removal of the implant along with the drainage device would be my suggestion, and I would persuade the patient to undergo this treatment in one sitting.
So we will go to Dr. Mani, and then GC sir can give his inputs.
I think I would go along with the majority here, actually. Implant is causing the problem and it has to be removed. But the problem is the trauma that is going to be caused by removing this implant. Probably it is a rare kind of thing, and the experience must be very less as well. So it's going to cause more problems, and wipeout has to be expected when we are going to put the implant, as well as control of hypotony in the post-operative period. And the worst problem in the long term would be corneal decompensation and an impending, DSEC or one of those procedures. So everything need to be explained to the patient, and it's going to be not an easy journey.
GC sir.
I had managed one patient along with Praveen Krishna where he also had to do a DSEC in the only remaining eye after removal of the implant. That patient also was very young, a lady, had lost one eye, and they don't realize the seriousness of the situation. That's the problem. The way the original procedure must have been explained to them and things like that, and the way they approach the whole thing is going to be very difficult to convince them. I would probably go to the extent of saying that anything short of removing the implant, if the patient wants that, if we do that, we are doing something wrong. Just like the original surgeon has done something wrong, doing something short of removing the implant is not probably appropriate. And the patient is with the implant or without the implant is waiting for a DSEC also, along with whatever needs to happen. If all that we do can retain the patient's vision for the next 5 to 10 years, we should be very happy. The patient is now in a very, very dire situation, and intervening and making patient realize that it's going to be a difficult job, and at the end of it, he may not retain the vision, is actually the most challenging part of taking care of this patient. What we do immediately is something different from how the patient is going to face it and how we are going to face the situation along with the patient 5 years down the line, I think is the major challenge. Best of luck to the surgeon.
Thank you, sir. Dr. Ronnie will ask Dr. Smita to continue, and then you can give your inputs.
Yeah, no, I mean, please, everybody is given the inputs. Smita, please do go ahead.
Yes, sir. So this was done for the patient. We planned for a iris prosthesis implant with AGV implantation.
Slideshow.
Yes, sir. And with the AGV implant at a GA, as the patient was very apprehensive, the AGV plate was secured in the superior temporal region, and a superior 2.7 keratometry was made. Viscoelastic substance was injected both behind and above the iris implant to take care of in case there are any adhesions. Micro scissors were used to create radial cuts inferiorly. With micro forceps, the distal part of this implant was grasped and the implant was removed through the incision made superiorly. The tube was then inserted in AC superiorly over the iris rim which was present there. The tube was covered with corneal patch graft and conjunctival closure. Viscoelastic wash was done. The patient did well post-operatively. This is day 4 picture. You can see the tube in the superior temporal region, and he had absent iris tissue almost 180 degrees. His pressures were maintained at 13 millimeters of mercury, and 1 week post-op also he maintained good pressure control. The final follow-up is awaited. So there have been several case reports citing that this bright ocular iris implant has caused a lot of adverse effect and necessitated explantation with procedures like DSEC. And few of one case report by this Mona Kwak et al. Says that those implants were done in India. This was the largest collection of the cases with this kind of implant, and you can see that most of these implants are done in countries like Tunisia, Lebanon, Turkey, Jordan. The morbidity which we can face with this, 80% of the patients can have uveitis, 50% of these patients had glaucoma, 50% had corneal decompensation. Only one of these 12 patients in this series was without any morbidity. The rest all patients had some kind of issue. All the patients were explained and advised for explantation with plus or minus whatever procedure was required. And 4 patients were so much motivated cosmetically that they refused the procedure. And the authors say that even after explantation, the patient can remain with permanent pupillary abnormality, uveitis, glaucoma. So a long-term follow-up is needed. So this is, I'm just showing the site of this implant. Their website, they advertise it so well, giving testimonies from celebrities that this changes their eye color permanently, and it is so good without any scientific data in their website. And they make it seem so easy that as if this procedure is equivalent to using contact lenses. So with this, I want this message to be taken that our attempt should be to increase awareness among the ophthalmologists of these devices. Our first aim is do no harm. No one must lose vision in an attempt to gain desired cosmesis. Thank you.
Thank you, Dr. Smita. Over to you, Dr. Manish.
Thank you, Dr. Ganesh. I think if we have any other comments from the panel, or else we can move to the next case.
Quick comment here. You have now left the patient with one eye cosmetic implant and the other eye with this thing. Now, what was the reaction of the patient for that?
So the patient is very much willing to get implant removal done in the other eye to get the cosmetic balance. So next visit probably that will be planned, sir. But only symptomatic management for glaucoma.
I'd just like to make one point that this patient probably had a pre-existing anterior segment dysgenesis. And it is absolutely criminal to do some sort of cosmetic procedure in an eye with such a high risk of glaucoma. And we see this all the time. We see I've had patients who have got LASIK with eye syndrome or with axon-filled triggers. And it's such a, I mean, I think general ophthalmologists should be aware that these are patients who you don't do any of these procedures lightly because the risk of glaucoma is just too high to ignore. So this is an extreme case, but I think it illustrates the point.
Thank you, sir. I think we'll move to the next presentation and by Dr. Mayank. Dr. Nikhil, sir, will you like to introduce Dr. Mayank?
Yes, Manish. I am very happy to introduce him because he is our own fellow, and currently he is at LVP, and he is a very sincere and hard-working fellow. So this is Mayank Rai, and Mayank, you should start your case now.
Thank you, Dr. Nikhil. So are my slides visible? So at the outset, I would like to thank the organizing community for wonderful opportunity. I'll be presenting an interesting case today. So my case is a 35-year-old male, known case of juvenile open angle glaucoma on one anti-glaucoma medication in both eyes. He was lost to follow-up for 2 years. At this visit, he came for routine eye examination. His best corrected visual acuity was 20/20 N6 in both eyes. All the anterior segment examination findings were within normal limits. Intraocular pressure recorded at this visit on Goldman applanation tonometer was 16 mm of mercury in both eyes. Angles were open on gonioscope. In right eye, the optic disc was medium size with a cup to disc ratio of 0.5:1 with a slight. There were few very narrow slit RNFLDs present inferiorly, which were narrower than the arteriole. In the superior and the inferotemporal quadrant, there are areas of reflectivity which is reduced, which could not be made out clinically. In the left eye, the disc was medium size with a cup to disc ratio of 0.65:1 with inferior rim excavation and a corresponding inferior wedge RNFL defect. There was presence of superior slit RNFL defects. Rest all posterior segment findings were within normal limits. Humphrey visual field analysis was done at this visit, and in right eye, HVF 24-2 was within normal limits. In left eye, HVF 24-2 showed superior paracentral scotoma, which was repeatable on 10-2. OCT was performed in both eyes using serous spectral domain OCT. The optic nerve head and RNFL thickness analysis was within normal limits in the right eye. However, in the left eye, there was a thinning in the RNFL thickness map in the inferotemporal quadrant with corresponding warm areas on the RNFL deviation map and the sector map. In right eye, macular ganglion cell complex analysis showed gross thinning of the RNFL with corresponding warm area on the deviation map and the sector map. Similarly, in the left eye, there was a thinning in the inferotemporal quadrant with corresponding warm area on the deviation map and the sector map. So now, recollecting the optic disc photograph and Humphrey visual field analysis of right eye, it is clear that there is no correlation between structure, that is ganglion cell complex analysis, and function, that is Humphrey visual field analysis. And even the optic disc findings in right eye are grossly within normal limit. So there is a clear-cut mismatch between the Humphrey visual field and OCT, and this can be labeled as worsening in right eye, or is this something else? Let us reanalyze and compare the ganglion cell complex analysis printout of right eye with left eye. The signal strength seems to be good here. But when we look at the horizontal B-scan image extracted from the macular cube, we can see that in the left eye, there is a clear-cut gap between the pink line and the yellow line. However, in the right eye, these two lines are seem to be coinciding. So now, what is this? Is this significant? We repeated the scans again, and this time, the right eye ganglion cell complex analysis was within normal limit. So let us now compare the horizontal B-scan image of our new scan in right eye with the older one. Now we can see that there is a clear gap between the pink line and the yellow line, which was not present in the initial scan. These two lines are coinciding. This brings us to an artifact which one should always rule out before analyzing any OCT image. Segmentation is the division of the image into various parts or subcomponents by computer algorithm that creates tissue boundaries based on difference in signal strength. This protocol enables us to perform a subcomponent analysis and diagnosis of glaucoma. The cirrus spectral domain OCT segments the ganglion cell complex, including the inner plexiform layer represented by yellow line and ganglion cell bodies represented by pink line, but it excludes the NFL. Segmentation error occurs due to improper identification of the limits of the structure by the segmentation algorithm. These segmentation errors are more common in the presence of poor signal strength, tilted disc, staphylomas, large peripapillary atrophy, epiretinal membranes, and posterior vitreous detachment. So before making a diagnosis on any of the scan, the clinical picture of patient should be given a look in totality, like in our patient, where the optic disc, visual field indices plot, HVF24-2, and RNFL and optic nerve head thickness map were within normal limits, but the GCC analysis was pointing towards worsening. Another example of structure function discordance is influence of axial length on OCT analysis. The refractive error in this patient in both eyes is around -19 diopter. There is presence of peripapillary atrophy around the disc, which is seen as false thinning of RNFL around the optic disc on OCT in the presence of normal optic disc and HVF analysis. Longer the eye, thinner the RNFL, and smaller the optic disc and neuroretinal rim area. For short hyperopic eyes, whose RNFL thickness and optic nerve head size may result respectively in higher and larger measurement compared with average eyes. These findings are ascribable to the axial length induced ocular magnification. In addition, myopes with long axial length often have blood vessels and the RNFL arcuate bundles deviated more temporally compared to a normal eye, which can cause an increase in temporal RNFL thickness and decrease in superior and inferior thickness. Structure and function discordance is also seen in advanced glaucoma. Though the HVF finding of this patient are suggestive of advanced visual field loss, but OCT shows comparatively thicker RNFL in both eyes, because in very advanced glaucoma, RNFL thickness assumes a plateau called the floor effect, not falling to less than 40 micrometers due to residual glial tissue and blood vessels. So OCT is not very useful in serial evaluation of these patients. For completion, we'll discuss two more common artifacts which can cause an error in analysis on OCT. A reduction in signal strength can result in loss of retinal layer features and introduce artifact in the RNFL analysis. The patient here has normotensive glaucoma in both eye and asteroid hyalosis in the right eye. That has caused the reduction in signal strength. The signal strength here is 6. This causes an inferior regional error of segmentation of RNFL thickness, which can be seen as a black rectangular area of absolute thinning on RNFL thickness map. The truncation of RNFL data is due to decentering on Z-axis. The patient has primary open angle glaucoma in left eye and is a glaucoma suspect in right eye. Displacement of scan along the Z-axis causes decentration of the nasal portion of inner retina to be truncated in the right eye. The derived RNFL thickness is showing a regional error here, which is seen as an irregular black rectangular area of absolute thinning on RNFL thickness map. So, to conclude, we know that early and advanced stage of glaucoma show structure and function discordance, whereas moderate stage of glaucoma has good structure and function correlation in majority of patients. So before making a diagnosis of worsening on OCT scan, one should look for the presence of any artifact which can cause error in interpretation. Thank you.
The message in this case, especially we would talk on the first case. Other scenarios were more for completion of artifacts on OCT. So the message in the first case was relatively straightforward, and this is a relatively straightforward case. And we know that in the early glaucoma, if we assess the structure on OCT and function on visual fields, Humphrey visual fields, there is a mismatch. But even keeping that in mind, there may be a tendency to jump to conclusion based on a single parameter. So the basic message is simple, that we should not conclusion from a single parameter, and there were clues to pick this up. So I would like to ask the panel that how often have they seen the segmentation error or other errors in OCT, and how did they impact?
Dr. Mang, please stop sharing your screen. Thank you.
Dr. Nikhil, if I may answer the question, it is fairly common to see these kind of artifacts, and I would suggest that if possible, one should go back to the machine and look at the images. If it is not possible, at least look at the the boxes which are given with the printout, and look at each of these, the signal strength, the presence of like a PVD, a partial PVD, which can be falsely recognized as the anterior margin, and the centration of the disc and the circle around the disc, and the segmentation map, which is usually given at the bottom of the printout. And most importantly, it is the correlation with the clinical data, and I think that is the one which will alert us that there is something wrong with the OCT. So it is very, very common. Like I would go on to say, if there are 10 OCTs, at least 2 or 3 will have such errors which are there. Not just segmentation errors, but artifacts which are in the OCT.
Yeah, true.
Can I make a comment? I think the fact that the macular scan showed a 30 micron thickness, that shows that there's some error in the measurement, because you cannot get such low values, especially with a normal disc. So I think systematically evaluating the printout would help us in picking up all these cues.
Yeah, exactly, because especially in a busy OPD, or if we are not tuned to look at every component, we may just look at the maps and go to the conclusion. That's the whole point. Relatively straightforward, but practically. Dr. Rani, would you like to add?
I have a question actually. There's a very well-defined nerve fiber layer defect on the photograph.
Yes.
You're not seeing it on the OCT.
Actually, in the right eye also there was a nerve fiber layer defect. Yeah.
That's why I'm asking. I mean, any thought as to why it didn't pick it up?
Clinically, when I saw the patient, superiotemporal and inferiotemporal, there was a bright reflex, and I thought it is a junction of dark and bright zone. But on the disc photograph, you see a demarcation that in the foveal region there is good reflex, and there is a zone of less reflectivity. So I don't know whether it has to do something with the ocular hypertension and early defect.
Maybe it's an artifact on the disc photograph. I don't know, because I think sometimes it may be a bit deceptive when you are having the disc photographs. The amount of flash that is being used and the position of the eye sometimes can be giving some artifacts on these. One got to be very careful. Looking at the slit lamp with your 90D or 7080, it should be giving you slightly better thing. So it may be very difficult now to go back and say that. Coming to the OCT artifacts, a quick comment. Dry eye is the most common thing which causes artifacts in these patients if the technician is not careful. And if especially if the ring is going to fall on the dry eye patch that is going to be on the OCT, that's going to cause a problem. Myopic eyes again causes problems. Visuomacular traction, if it is going to be there, its segmentation errors are common with that. Almost 20% to 30% of OCTs in the clinics have segmentation errors. That's the literature. So one got to be very careful. Looking at the horizontal scan is a very good practice, and looking at the signals also.
Even toxicity to benzalkonium chloride is, I have seen, quite common and usually not picked up. Even I have seen a generalized depression on visual fields by back toxicity, and when you change the medicine to back free, it disappears.
Was a 10-2 done in the right eye? I mean, we were seeing a few slit-like defects. So sometimes the defects can be missed on a 30-2 or a 24-2, and the defect may be picked up on the 10-2. Was it done on the right eye?
No, it was not done. Because clinical examination, no doubt with the RNF. 24-2 was fine. So.
If if I may add, if you are using your OCT with other colleagues like retina you're sharing, the spectrometer has to be assessed very regularly. That also contributes to the signal strength, and if it's not good, then you may have to change it in the AMC.
One of the recent thing that happened was for COVID situation, people were using a plastic wrap in front of the OCT, to avoid, for safety measures. And that was giving a reflectance issue and causing artifacts. So one got to be careful when we are trying to have some measures in place for, additional things on OCT.
Do you usually do an axial length before you send the patient for the OCT? Like because the axial length ranges from 22 to 28 millimeters for the Zeiss OCT. Anything beyond that, like Dr. Mayank presented, you would get a you won't get accurate scan.
Dr. GC, have you published your axial length and OCT data?
No, I don't think so.
Okay, because you had some fairly interesting findings in that thesis actually.
Yeah. We have to work on that.
I mentioned this from the manufacturer's brochure. That's the recommendation.
So one of Dr. GC's PhD students has done some work on this, and it's fairly interesting. So I'm sure the data will come out.
Would it make a difference during follow-up? I don't think so. If you're using it for follow-up and not for a cross-sectional analysis.
Yeah, but if the error is not corrected, when we repeated the scan, then the error was corrected. If you don't do that, then it will show in the serial analysis.
I would reiterate the point made by Ronnie.
Sir.
For doing a 24-2C for everybody instead of a 24-2. So what are the thoughts of the panel?
24-2C is probably useful for screening to pick up a diagnosis, but if you need to follow up the defect, I think 10-2 is still needed. In this patient, I'll make one point that with the established glaucoma in the left eye, with whatever is looking suspiciously like a superior nerve fiber layer defect in the right eye, even if it is not picked up by the OCT, doing a 10-2 I think is worthwhile. And if there are the optic disc and nerve fiber layer photographs present over a period of time, comparing to see whether it's an artifact or what it is and whether there is any change in that. I think the right eye will require careful follow-up. Obviously, it will be done because the left eye is having glaucoma, but that appearance of a nerve fiber layer defect superiorly needs to be watched very carefully, both with 10-2 as well as with the OCT.
I think, should we move to the next case, sir?
Yes.
We'll share this. So, Dr. Ganesh, will you like to introduce Dr. Vinod?
you. Oh, yes. I'm very happy to introduce Dr. Vinod Arnachalam. He is from Trichy. He has passed his MBBS in 2009 from Ramachandra University, Chennai, and completed MS in ophthalmology from Annamalai University. He did his fellowship with us, and he has been regularly contributing by way of posters and talks in the national state conferences. He's been a faculty for all our CMEs, which we are being held in our center here in Coimbatore. Over to Dr. Vinod to present his case.
Thank you, sir. Thank you for the organizing committee for giving me the opportunity to present in this webinar. Is my screen visible, sir?
Yes, visible.
Good evening, all. So today we're going to present our case about our JOAG, a bloodless surgery, where a 35-year-old female came with the complaints of defective vision, where her uncorrected visual acuity was 4/60 and 2/60, the right eye, left eye respectively, whereas on right eye correction of -5 sphere with -1.5 cylinder, she was improving to 6/6 partial, and left eye with -8.5 sphere and -3 cylinder, she was improving to 6/9. The intraocular pressure in the right eye was 54 mm of mercury, and as in the left eye it is 50 mm of mercury, and gonioscopy showed open angles in both the eyes. Coming to the anterior segment examination, where all the parameters were normal except the RAPD was found to be seen in the right eye, and she gave a where her father is a known glaucoma patient where he is on regular medication. And a fundus examination revealed of a 0.95 CDR near total rim loss in the right eye, and whereas the left eye it is around 0.8 CDR. So we started on medical management, where bromelain timolol combination and latanoprost was started in both the eyes, and she was asked to come for follow-up. On follow-up, her IOP was around 39 mm of mercury in the right eye and 20 mm of mercury in the left eye. So we added medication of dorzolamide, and in the follow-up with the dorzolamide, in spite of adding dorzolamide, her IOP was 40 mm of mercury in the right eye and 20 mm of mercury in the left eye, and we added pilocarpine. And this is the anterior segment picture and the gonioscopy picture, where we can see the anterior insertion of iris has been seen clearly in the gonioscopy picture. Where on follow-up, in spite of adding all 4 medications with the pilocarpine, her IOP was 34 mm of mercury in the right eye and left eye was around 18 mm of mercury. So we planned for a surgical intervention. We decided to go for a GAT, goniosteroid aventine trabeculotomy. Where for this is a HFA picture of the right eye of 24-2, where visual field index around 10% and mean deviation is around 30.74 decibels, and 10-2 is around -30.57 decibels, where it's a very advanced disc damage has been seen. Where left eye shows pretty okay, where VFA was around 98% and mean deviation was around -6.77 decibels. She underwent GAT, where on first post-op day her visual acuity was 6/24 and IOP was 18 mm of mercury, and her anterior segment was within normal limits in the post-op, where there is no minimal inflammation and there was no hyphema. And post surgery, we can see the trabecular meshwork opening is there, and we can see the pre and post gonioscopic differences in the picture. We were asked the patient to come for a 2 weeks follow-up, but where the total lockdown came, so the patient didn't turn up for the follow-up. Where she came for the follow-up after 3 months, once the lockdown things were becoming normal, and the follow-up of 3 months post-op, her IOP was 17 mm of mercury in the right eye and 25 mm of mercury in the left eye, where left eye IOP has been increased. And we asked them to come for a 1 month follow-up later, where at 4 months of follow-up, her IOP was 16 mm of mercury in the right eye and 25 mm of mercury in the left eye. In spite of adding medication in the left eye, IOP was not coming to within normal limits, so we planned for the surgery in the left eye, and same GAT procedure was the patient underwent for the left eye. At the post-op day 1 in the left eye, her visual acuity was 6/18 and intraocular pressure was 12 mm of mercury, where anterior segment within normal is at this time, except for the trace hyphema was seen in the left eye, whereas in the right eye everything was normal. Left eye we had a trace hyphema that was cleared at 2 weeks post-op, where IOP was 14 mm of mercury in the left eye at the 2 weeks post-op. So the advantages of going for a GAT, where we can preserve the tissue and we can plan for additional future surgery if possible, if needed. And I want to share a few articles on GAT. Where this is by Dr. Grover et al. On treatment of GAT treatment for the primary congenital glaucoma and juvenile open angle glaucoma. 14 eyes of 10 patients underwent GAT with a follow-up around 12 months, where a patient aged from 17 months to 30 years, and early postoperative hyphema was the only complication where they had, and the mean IOP reduced from 27.3 mm of mercury to 14.8 mm of mercury. And this is the UBM image published in JAMA Ophthalmology following a GAT procedure. That's a tangential limbal cut and equatorial limbal cut, where we can able to see the open Schlemm's canal and unroofed trabecular meshoak leaflet in both the tangential and the equatorial cut. This is another article that shows about a 24 months follow-up following GAT, where this is a number, so 198 patients, a big number has been included, where age group also wide age group from 24 to 89 years underwent the GAT procedure, and the mean IOP has been reduced for averagely around 14 mm of mercury has to be drop seen in the pressures from the baseline. And this is another article sharing GAT after any incisional glaucoma surgery, where 35 patients were included in the study, where of them 19 had a prior trabeculectomy, 13 had a drainage device, 4 eyes had a prior trabectome, and 5 had a prior endocyclophotocoagulation. But this also had a promising results. But this is GAT has been done by the thermal suture modification, where this photograph has been showing the tip of the suture has been marked with a surgical pen, and then we used a cautery to blend the tip, and this melts the tip of the suture, and then we can incorporate the ink into the suture. And following the valence of solution wet sponge, we used to remove the remaining ink from the tip. So at the final picture, we can see the permanently marked tip has been used for the procedure. And another article where they have combined both GAT as well as a cataract surgery, where they have seen around IOP reduction of around 11.2 to plus or minus 2.4 mm mercury from the baseline, and in all the postoperative follow-ups, IOP was significantly lower than during the preoperative period. So 32 eyes underwent this procedure, and they had a promising results. So thank you. So we can consider GAT as one of the surgical option for the JOAG patients.
Thank you, Dr. Vinod. I would put this to the panelists. Dr. Ronnie, we had a tip blunted, and we're using a Hill gonioscope, surgical gonioscope we introduced in the Schlemm's canal. It was the first attempt of mine, and I was very surprised to see the successful result. And then we proceeded to do it in the other eye also, because it worked very well. Usually we do a trabeculectomy with mitomycin C, but somehow, because the angle was quite nicely visible, we were very, we thought, trabeculotomy would be the ideal, but we wouldn't like to touch the conjunctiva. That's why we proceeded with this. Any thoughts on this? I was also very surprised by the and the appearance of the anterior segment in the next post-operative day. Both these situations, we were told we will have a lot of hyphema with low vision. Patient won't be able to go home. Needs help. But I saw I was so white and quiet. It was quite surprising. Now, as of now, we have done about 9 surgeries, and almost all of them behave the same way.
I think all credit goes to the surgeon, Ganesh.
No.
So, what viscoelastic did you use for the procedure?
So this is we use oro gel, which is high hyaluronidase by Orolab. And initially I was very eager to use it, but now what I started doing is I would use 50% oro gel just to deepen the chamber. The next will be normal your HPMC. That's it. Fast to clean, quick to clean, doesn't leave any residues, not much of inflammation. So the second part of the procedure, I would just go ahead with the HPMC. I wouldn't use too much of Orogel.
And you use the standard instrumentation or?
Yeah. So we use the Grishaber forceps for introducing the suture into the Schlemm's canal. But now we're using the MVR blade. For the first, this particular patient, we used the MVR blade. But now I found that even using a 26 gauge needle to slit open the trabecular meshwork works just as fine. We were always been told that 270 degrees you would get stuck. After that, it's a little struggle. So that has happened. But once I found that you could even reverse it, that helps a lot. You could do a 360. All the 9 patients we have done so far, we got a 360 degree achievement of the passage of the suture.
So you did a 270 one way and then you go the other way. Is that right?
Yeah, but you don't have to. You continue. So you come out 360 degrees.
Okay. And all these patients are very well selected anterior iris insertion JOG. So
anterior, and I wouldn't be very happy to do GAT because there's no space. They're very close. These are eyes which are deep chamber, but the iris is sort of concave, and you can have the insertion anterior to the. So you have to go there, slit a little bit, cut open, and then introduce the suture into the track. So my principle is that anterior iris insertion, I think it's anomaly. I really wouldn't touch those eyes with a angle procedure.
So mentioned anterior iris insertion, that's why I just wanted to clarify.
Yeah, anterior insertion, but concave iris configuration.
And the very dense iris processes.
Yeah.
I just, from my point of view, I just make a comment that it's technically fairly challenging. In Ganesha's hands, it works well. So you have to be fair. I mean, I would not say that anybody and everybody could go ahead with doing it, and it's very often combined with a cataract surgery because that deepens your.
More than the procedure, we wanted to show the anti-segment photographs. Now, the first post-operative day. That's what we wanted to show.
Untouched, actually. Any comments from
Dr. Bhaskaran?
I think your use of the Orogel probably prevented the influx of blood for the first probably a few minutes, and that would have helped a bit in your next day post-operative feature. And in my interactions with the Japanese colleagues when I was there, they were doing this trabeculotomy even for primary open angle glaucomas. But I don't see any proper level 1 evidence on this procedure, so that we can all start using this in a wide hope that you can in your practice may be able to get that information, and it will be very.
Dr. Andrew?
Well, again,
your experience with the Zen chant. Thanks for lending me the videos and the photographs.
I have experience with this procedure. Okay, and I think that it definitely requires a fairly good level of surgical skill. It is something that I think is possible for all of us to learn, but where exactly its place is in the therapeutic armamentarium that we have is still to be established. And for that, we need to know, how applicable it is, what are the potential complications, and that would not with carefully selected cases and a very skilled surgeon, but over a wide range of cases. So, however, I think it definitely has promise. And, there are all sorts of combinations that one can try. I've heard the argument proposed that one should do this for angle closure patients, because when you kind of, slit open the Schlemm's canal, you'll cause the iris to fall backwards, and you can even put forward the argument that you can then put a circular suture around the pupil and try and pull the iris centrally and augment the procedure. So all these things are theoretically possible, but one has to kind of evaluate it very, very carefully. We are just in the beginning stages of looking at things like this, but it sounds very promising.
Dr. Gauri, your take on this?
Yeah, as everybody said, Dr. Ganesh, it works in your excellent surgical hands. And though I have no personal experience with GAT, I have not done even a single one. There are a few things that I would keep in mind when I'm treating this kind of a patient who has a very advanced field loss and is young with raised pressures. So one, use of the highly retentive viscoelastic. If you do not wash it out properly, if you leave even a little bit in the eye, it can lead to a lot of post-operative IOP spikes, which can be very damaging in a disc as damaged and a field as damaged as what we have seen. And second, any false passage which leads to a hyphema, even that can complicate things, and that can be costly in this particular patient who has a very severely affected field. That is my major concern in this particular patient, where the field is so much affected. He has a lot at stake. So if even a gross postoperative fluctuation can result in a significant change on the disc and the field. So that's something which will be on the back of my mind when I'm looking at this kind of a procedure in this patient. Because in the earlier stages, when I did ECP for phakic patients, in patients who had very poor vision, there also you use highly retentive viscoelastic like Helon 5. So if we don't wash it out properly, the post-op IOP spikes can be very significant. And in fact, we have to keep them and watch out for these spikes. So that was what I had seen. So that is the only comment I would like to make.
Some of the later patients had a steroid response. So once we saw that the eye is quite, and so we started tapering the steroid within 15 days. We asked them to apply 6, 5, 4, 3. Within 3 days, they bring it down to once a day. By the time they come, steroid responses documented literature to be the main reason for a rebound fluctuating IOP. Dr. GC, your take on this, sir? So you'll have to unmute, sir, please. Thank you.
Nothing beyond what people have said already. It's a technology in evolution. So we need to wait and watch the level 1 evidence that Bhaskar wanted.
Yes. Dr. Shanta?
I agree with all the comments, and I think it is quite courageous to try it in this patient with such advanced glaucoma in the right eye, as Gauri had commented. So it's your surgical skill which brought about this result. So until we have RCT, I think it's possible for you people to do more than anybody else. Comparing it with the gold standard, which is the trabeculectomy, we won't have enough evidence to use it.
Yeah, the only concern was the risk which we are going to take is almost the same which we apply to even trabeculectomy, and plus she has a strong family history of glaucoma and a father, and then this was a very advanced field. So we thought if we do a conjunctival sparing procedure, since we don't have any mixed device, of course MIS is not applicable in this situation because of such high pressure. Any conjunctival sparing procedure, she is only 30, 35, 40, 39, 40. It would be helpful for her in the later stages of her life. No other comments. We'll hand over to Dr. Manish again. Thank you.
Thank you, Dr. Ganesh. I think move to the next presentation where Dr. Shruti. Dr. Nikhil, will you like to introduce Dr. Shruti?
Yes, it's my pleasure to introduce Dr. Shruti. She has done her MBBS from Vijayanagar Institute in Ballari. Then she has done DNB in Shankar Hospital, Guntur. And she has done fellowship in glaucoma from Narayan Netralaya, Bangalore. And presently she is working at Narayan Netralaya, involved in the research. And I like her statement that she believes in creating awareness among people that glaucoma is irreversible. Over to you, Dr. Shruti.
Good evening, everyone. Thank you for the opportunity for presenting the case here in this platform, and thank you, everyone. I'm presenting a case of 73-year-old male who presented to us with blurred vision in right eye since 2 weeks. His old records revealed that he did not undergo any intervention in his right eye, though he had undergone cataract surgery in the left eye 2 years ago, and he had also received intravitreal injections for CME associated with vein occlusion. He was already using anti-glaucoma medication in his left eye, that is brinzolamide and timolol, and he was a hypertensive since 5 years. Coming to the ocular examination, right eye vision was 660 and N18 with pressure of 24 millimeter of mercury. Rest of the anterior segment was normal except for the presence of pseudo-exfoliation and cataractous lens. Gonioscopy showed occludable angles opening on compression in all the quadrants. Of course, posterior segment had a hazy view due to the cataractous lens. Coming to the left eye, vision was 6.9 N10, pressure was 15 mmHg with medications. Again, it was a pseudo-phakic eye with the presence of RAPD. Gonioscopy had open angles with no evidence of neovascularization of angle and irregular TM pigmentation. It was a medium-sized 0.8 to 0.9 cup disc with pale, thin neuroretinal with evidence of old CRVO, that is sclerosed vessel CME hard exudates in the left eye. In view of occludable angles, he underwent LPI and post-LPI angles opened. So post-dilatation, we could see the evidence of vein occlusion in his right eye as well. That is, we can see the hemorrhages in all the quadrants. It was a medium-sized 0.6 cup disc with a sloping inferior rim, hard exudates, and the OCT macula showed CME, for which he received anti-VEGF in the right eye. Once the macular edema resolved, we did visual fields. So right eye visual fields were reliable with superior and nasal field defects, and left eye shows advanced field defect with few central good points. Since IOP was under control in the left eye, we advised to continue the same medication, and no much intervention was done in the left eye. Now, in view of the field disc changes and raised pressures in the right eye, we started AGM. So that is brinzolamide and timolol. Once we put on the medication, IOP was well under control. So when he came back for the cataract surgery in the right eye, pre-op OCT showed some macular edema. So he underwent clear corneal phacoemulsification cataract surgery with implantation of IOL with injection anti-VEGF. Surgery was uneventful, and at 6 weeks, vision improved to 6.9. There was no CME, and pressure was 18 mmHg with AGM. So I would like to continue the interventions done in the right eye from now. So 3 months post cataract surgery, he again presented with blurred vision and pressure 28 mmHg on AGM. Eye was doe quiet. We added brimonidine to the already existing anti-glaucoma medications. OCT showed macular edema, so he took injection anti-VEGF once the IOP was under control. So 1 week post anti-VEGF, he came back to us with presence of redness with drop in vision and raised intraocular pressure. I showed signs of acute granulomatous uveitis. Here we started oral acetazolamide and continued with topical AGM, and we continued topical steroids. Here, brimonidine-induced uveitis and post-injection reaction was kept in mind as the differential diagnosis. So 3 weeks post-injection, we saw him again. There was persistent AC inflammation and vitreous haze was present. So he underwent FFA, which showed no major blood vessel leak, but macula showed edema. So AC TAP was done, and there was no bacterial agents, and culture sensitivity was also negative. Here, we thought brimonidine-induced uveitis might be the reason, so we stopped the brimonidine and continued him on oral acetazolamide. Once the IOP was under control with oral acetazolamide, IVTA was given for the intractable CME. So again, he had got recurrent CMEs, for which he took 2 more doses of IVTA. But 1 month post third IVTA, he took 3 IVTAs like that, pressures were under control. 1 month post third IVTA, CME was resolved, vision was improved, but IOP remained high on oral acetazolamide, brinzolamide, and timolol. AC was quiet, and gonioscopy showed no evidence of neovascularization. And optic nerve showed further thinning. Glaucoma was progressing here. So we did fields. Field was also showing progression. So I was not left with any other choice. So for the pressure control,
I went ahead and did trabeculectomy with MMC with 0.4 mg with IVTA injection. Trabeculectomy surgery was uneventful. We followed him post-operatively regularly with antibiotics, steroids, and steroids and cycloplegics. So until 3 weeks. At 3 weeks, there was a good blood, no leak, IOP was well controlled, AC was quiet, there was no edema, vision was stable. Unfortunately, we lost for the follow-up due to pandemic for 3 months. So when he came back at 4th month post-surgery, again vision was 612 N18, IOP was 29 mmHg, and on dorsalamine timolol. Here in between, during the pandemic, patient couldn't come to our hospital. He had gone in between to other local ophthalmologists, for which he was, for the raised pressure, the local ophthalmologists already had added medication. So on dorsalamine and timolol, pressure was 29. So on examination, there was a flat blood, subconjunctival fibrosis, and trapped stoma was patent on gonioscopy. So ASOCT also showed fibrosis, subscleral and subconjunctival fibrosis. So needling with 0.1 mg MMC was done. Post 6 weeks needling, IOP remained high. There was no evidence of neovascularization and gonio. Again, CMV was there. If FFA showed multiple peripheral CMP areas and blocked fluorescent areas. PRP was planned, pan-retinal photocoagulation was planned, but couldn't be completely done in view of non-dilating pupil, presence of PX. Here oral steroids was started. So I went ahead and did AGV implantation with sphincterotomy under the steroid cover. So day 1 post AGV, pressure was 24. AGV plate was well covered with no exposure and no evidence of leak. There was corneal edema. Pupil was 7 mm dilated post sphincterotomy. 1 to 2 mm of hypopyon cells flare membrane was there, and there was a long tube in the sulcus. Longer are riskier to cause tube corneal touch. However, there was no tube corneal touch. AC was sufficiently okay. AC was deeper only. So lens was there, PCI wall is in the bag, and posterior segment was very hazy view. Sorry, I couldn't take the picture here. He was followed up, sterile inflammation was kept in mind because we had done a lot of manipulation with the iris for doing the sphincterotomy. So we expected sterile inflammation and we waited. We saw him on day 5. By day 5, hypopyon resolved and inflammation was better. When we saw him on day 10, it was vision was counting figure 3 meters and pressure was 12 mmHg, but AC was shallow now. But inflammation has subsided, but AC became shallow. There was a long tube in sulcus, as you can see in this picture. Though the tube looked longer in the dilated pupil, it didn't have any tube corneal touch. On posterior segment examination, we could see choroidal detachment. So topical steroids were increased to hourly, oral steroids were continued, and antibiotic and cycloplegics were continued. So 3 weeks post AGV, there was a persistently low IOP, that is 5 mmHg. There was no leak still, and AC remained shallow. There was long tube, and choroidal detachment was also persistent. Again, when we saw on 1 month post AGV, the choroidals were persistent, and IOP was still low, and macular edema was present. So I would like to ask the panelists at this juncture what to do. So the reason why I explained the whole story behind why I did the AGV was, in between I was stuck because brimonidine induced uveitis, so brimonidine cannot be given, CME was there, PG analogs cannot be given, and IOP was not controlled with only oral acetazolamide, brinzolamide and timolol. So how would you suggest the management differently? What could be done? And at this juncture, what can be done is my question to panelists. So one thing I was stuck is pseudo exfoliation component was there. And steroid response, I couldn't figure out whether it was steroid response causing raised pressure. And it was contraindicated that PG analogs could not be given because of CME. And brimonidine-induced uveitis was one more differential diagnosis kept in mind. So I was, so whether the management we did it was okay, and how differently it could be
You can
managed.
stop sharing your screen so that we can have.
Dr. Shruti, it is a difficult case to manage as you have gone through. But one thing, the episode of granulomatous uveitis or the uveitis and this thing was immediately after the injection of an anti-VEGF.
Yes.
So which anti-VEGF was used? Sometimes if it is these biosimilars, some of them can incite inflammation. So that is a differential diagnosis for brimonidine-induced uveitis. So we've seen such reactions with Avastin and with Razumab. So the biosimilar which is there. So if it is one of these, then it may be, that may be contributing to the inflammation as a differential diagnosis to the brimonidine. And second, you mentioned that the arm to retina time was delayed. So was a carotid Doppler done? Why was the arm to retina time delayed? Was there a component of ocular ischemia? If so, then what happens is that the ischemic component also affects the ciliary body. And a patient can quickly go from raised IOPs to hypotony. Like for example, in an ocular ischemia patient, if the pressure is like 34 or 35 with neovascularization, and I give him one tablet of Dimox and the pressure drops to, sometimes it happens, it drops to 10 or even single digits, that means that the ciliary body is at the borderline of its functioning. Okay, so the outflow is blocked because of the other things which are happening, but the inflow is like on the border. And quickly such ocular ischemic syndrome cases can land into hypotony. These are two of my comments which I thought I would make.
I think I would agree with Dr. Gauri. And the other thing which we have to take into account is why do you have CRVO in both eyes? The first eye also had CRVO, which was lasered, I think. The right eye is also, once you did a PI, then you saw the patient is 78-year-old person who's 78, 73, 78, I think. Yeah, who's got hypertension. Now, that hypertension has to be really well controlled. To contribute to all these problems and be associated with pseudo exposure.
Yes, sir. Carotid Doppler was done, and it was no evidence of narrowing was there, ma'am. There was no emboli or no significant thickening was there. So all the workup was done for, when he came to us. Only workup was done when he had left eye CRVO. So
still we have to keep that in mind, because when what Dr. Ganesh said is very significant. There is CRVO in both eyes, and carotid Doppler are telling about the large vessels, but what happens to the small vessel?
no.
Retrospect, it looks like there may be ciliary body ischemia the way it is behaving. But it is good that we did not put a non-walled implant. It would have been scary.
I would definitely consider doing a UBM too, because when you go in the sulcus with a tube, it's quite possible that you can create a small cyclodialysis which you may not actually pick up very easily on a gonioscope, because the tube is also in the same area. So doing a UBM to look both for a cyclodialysis and for vascular membranes, which again can cause hypotony on their own in somebody with this sort of a inflammatory pathology, are worth ruling out.
Actually, the aqueous suppressants were continued in the immediate post-operative period, the timolol and dozolamide.
No. Post-operatively, I have discontinued the drops. I was thinking if the pressure builds up in second week, I will restart it. But he came back with the choroidal detachment, so we didn't start it now.
Of these triamcinolones, especially there were 2 injections given intravitreal, so this can be very refractory, and sometimes these remnants will continue to keep the refractory part high. I'm not sure if it was removed remnants, whether it was possible at all. And again, I think in the long run, what Dr. Gauri was pointing out, the ocular ischemia part can be one thing to play for the hypotony, which we should keep in mind. Yeah, but I think worth doing the UBM to check for any small CD clefts and manage it.
I think uveitis played a role here, sir. So I would like to consider when the UBM at this. It was post-op patient and this corona, this thing contact procedures avoided. That's why I didn't do UBM. I did ASOCT though. I have not put the picture here. It didn't show any cyclodialysis cleft evidence.
But the ASOCT is unlikely to pick up every cyclodialysis.
Yeah.
So.
Versus UBM. At this era, I just didn't do it because with the post-operative patient, I was worried. That's it, sir.
No, that's fair enough. I mean, it's not a.
When you suspected brimonidine allergy, did you look at patient after stopping the drug? Because I have seen this, like every visit, brimonidine allergy is quite common, and if you do not evert the lower lid and look for the signs of toxicity, it often goes unnoticed. And there are patients who present with quite significant inflammation, even like acute granulomatous picture I have seen. So did you, I mean, if it goes on, then the inflammation can be quite significant. So did you look for stopping the drug and saw any change in the inflammation?
So we stopped the drug, sir. The lid showed congestion only. There was no significant follicular reaction though. So I was like bit confused. He was also telling itching complaint. So itching is very non-specific, whether it is due to brimonidine or I couldn't understand. There was in fact mild lid edema with itching and congestion and this granulomatous uveitis like picture. So he had received a number of anti-VEGFs before also. So I don't know whether it is post-anti-VEGF tachyphylactic reaction or it's a brimonidine induced. When we stopped brimonidine, the AC inflammation settled. So we thought it might be brimonidine induced component is there.
But then it was restarted after the trap. So then maybe I would not have started it again.
No, it was not started. Only timolol and dorzolamide just started.
Yes, only dorzolamide and timolol.
Oh, I'm sorry, I missed.
There's one more rare possibility that we need to rule out, and that is a perforation at the time of the AGV. Unlikely because early post-op your pressures were okay and they just continue to decline. But sometimes rarely you can actually manage to perforate while suturing the plate.
The AGV valve damage, sir?
No. You can perforate the globe while suturing the plate.
Okay.
But it's a very rare complication.
I think is an issue with any implant because when we are putting with, say, if you are putting a 23 gauge needle, then there is a struggle to put the tube, and in that struggle, the eye may become soft. If we use a larger needle, there may be a peritubular leak, and it may be happening. We don't know. So now I have got a feeling that I started making a rectangular flap. So I make a flap because my feeling is when you enter the eye with the needle, the globe becomes soft. So the limbus collapses and that causes resistance for you to put the tube inside. So I make a rectangular flap, lift the flap with the forceps and then put the tube inside. This has significantly reduced the struggle to insert the tube inside. This is especially good for fellows. In the first attempt, the tube can go inside.
This is a very good technique. This is a very good technique. If you want to place it in the sulcus, you could go deeper. If you want to place in the antechamber, you can go straight.
Yeah, you can see the anatomy of limbus well. And at the end, you put a glue and then put two sutures. So that glue, if any peritubular leak, that glue and the flap should resist.
This is for the general audience who are listening. If you have multiple tracks and you have used only one, it's very important that you suture all the other tracks. That's something which is very important we should do.
So you will place the tube under the flap and there is no need of patch graft again to close the tube, sir?
No, this flap is about 3 millimeter.
You need to put again one more.
Yeah, behind that I put a patch graft, or you can make a scleral tunnel and the posterior part of tube can go through the scleral tunnel. Either.
always safer to put a patch graft because
Yes.
there is a risk of melt even
The
with.
the function of the flap is just to give you some way to give counter traction for insertion of the tube. You see the insertion of the tube with the flap. I mean with a patch graft. So
Yes.
the flap is just for the counter traction. As you said, it's a small flap.
Yes.
So yeah.
Also, when you cut the tube, sorry.
No, I think it's type to assist in covering the portion of the tube which is between the point of entry and the corner patch.
Yeah.
So if you have this rectangular flap, it can cover that area of the tube and adds additional protection. So that's another advantage.
Yes.
Another tip during insertion of the tube is if you have a long bevel, like if you cut it so that the bevel is long, then it has a tapered kind of profile. So that makes it a little easier to insert the tube.
That's right.
And also if you turn it downwards, like you twist the tube and then put it with bevel down, that also is a little easier. Okay, so these are all small things. It is difficult when the AC has collapsed to, insert the tube.
So, Manish, you want to do closing remarks?
I think we can close the session. There are two questions from the web link which we have. So I'll just quickly ask those questions. One question is by Dr. Anumeha, that implant had been there in the eye. I think this is for Dr. Smita. Implant has been there in the eye since 6 years, a long time. Not
Excuse me, sir. Sir, I have to finish it off.
Go ahead.
So what did we do in this case? I just want to tell, sir. So we did sectoral PRP with IVTA again. So the reason behind giving IVTA was to avoid further choroidals. So 8 weeks post AGV, patient presented with 636 vision and pressure was 12. Choroidals all resolved and AC was deepened. OCT showed resolving CME. So there was no choroidals. This is a optos picture and this is the AC deepened with the AS OCT and resolving CME. So in my case, it was ciliary body shutdown. We feel the cause for the hypotony and other causes, as we have discussed, I will not discuss it. Preventive measures, almost everything was discussed. From my literature search, the other treatment options we can do is we have to treat the cause. Basically, conjunctival suturing if there is any wound adhesions noted. AC reformation with viscoelastic injection, though a temporary measure, can be used to buy time for the posterior segment pathology to become better. Tube ligation with polygalactin sutures are the newer techniques to avoid hypotony. And intraluminal stenting with 4-0 nylon is also a newer technique. And choroidal drainage should be kept at the last when if the AC is shallowed and there is kissing choroidals. The choroidal drainage should be the last option. So these are my thank you so much. I thank everyone to give for giving the valuable inputs. I will definitely incorporate into my practice. Thank you so much.
Thank you, Dr. Shruti. It was a very nice interaction. Thanks for the case. So I'll just quickly read out the two questions which we have received. First by Dr. Anumeha is, implant had been there in the eye since 6 years, a long time. It may not be causing any fresh damage to the eye. Whatever damage had happened would have happened long back. Then why was not just do AGV surgery without removal of implant? This is a question I think for Dr. Smita. Would you like to answer this question?
Yes, sir. I don't think the implant has caused damage and is not causing damage.
Probably
The thing is the mechanical inflammatory process is still going on. So if the patient is just left with AGV and the implant can cause further decomposition of the cornea. So there is no point keeping the implant inside thinking that something that has been done earlier and it is not happening now.
And keep in mind that you're having a progressive iris genesis. I think it will forward. That's going to push the implant even more forward, and you're going to monetary compensation.
And just one more question, I think the question is by Dr. Reni. This is for Dr. Ganesh and Dr. Vinod. Was additional treatment given post-GAT for the right eye as the intraocular pressure was 16, considering the amount of damage?
Yeah, I mean, you could treat, but if you remember the baseline pressures of 52, we have almost dropped it to, almost 80% IOP drop. So since we have brought it so low, and plus we have the conjunctiva to spare, we would like to keep it as untouched as possible till we find a sign of progression or the patient is uncomfortable with her vision, then we would try to treat. That is the main idea of doing a conjunctival sparing procedure, that you don't touch the conjunctiva either surgically or medically for that matter. And as your patient has a history of glaucoma in the family, she is well versed with what has happened to her father. So since she knows all that, so we are confident that we should be able to give her, she should be confident in us, and we should be confident in her to share the information as regards progression. So as of now, we saw her yesterday. She has pressures of 14 in the right eye and 16 in the left eye. She is doing pretty well. So we will just continue to monitor her like so.
Is the visual fields stable, Dr. Ganesh?
Visual fields, the visual field which you saw is actually done post-operatively, because we couldn't do a visual field when her pressure was, and she was -8 in that eye. So when she came back, that's the visual field which you have seen. So we operated the left eye recently, just about 3 weeks back. So she is due for the visual field next visit. So we'll do that.
Thank you, Dr. Ganesh. I think since we're already running 15 minutes late, so with permission of the chair, Dr. GC sir, we can close this session. I'd like to thank all the speakers, panelists, and the moderators. We really had a very useful discussion. I really learned a lot of new things. I'm sure we all had good interaction. I request Mr. Nagmohan, GM Sales and Marketing, Avesta, to formally give the vote of thanks.
Yes, sir. Thank you. Good evening, sir. On behalf of Sun Pharma Avesta Division, we express our sincere thanks to Dr. G. Chandrasekhar, who gracefully accepted our invitation and chaired the occasion today. And we also express our sincere thanks to Dr. B. Shanta, Dr. Andrew Veganja, Dr. Gauri Murthy, Dr. Bhaskaran, for being the panelist of this program. We also express our sincere thanks to Dr. Roni George, Dr. Ganesh Raman, Dr. Nikhil for excellently moderating this today's program. We also express our thanks to Dr. Manish Singh, being a program coordinator. Nevertheless, to mention, we express our sincere thanks to Dr. Manju Anu, Dr. Smita Panda, Dr. Mayank Roy, Dr. Vinod Arunachalam, Dr. Shruti S, for their wonderful presentations. Lot of knowledge has been exchanged, and I hope that we all enjoyed. I hope you also enjoyed this program, and it is very nice to have you all in this program. Thanks being with us, and thanks a lot for accepting the invitation, and thanks for making this program a grand success. And before we close up this today's program, we express once again our thanks to Dr. Roni George as well as Manish Singh, Dr. Manish Singh for conceptualizing this program and make this program a grand success. Thanks a lot once again being with us, and we look forward to meet once again in the next round in next month. Thank you so much. Once again, thanks a lot being with us.
Thank you.
Thank you, sir.
Thanks, everyone.